Welcome to the Explainer. Today, we are cracking the case of the stiff heart, restrictive cardiomyopathy. We're going to break down everything you need to know, especially for your exams.
Okay, let's just dive right in. Here's our game plan for tackling this super high-yield topic for your PANCE prep. We'll start with the core problem, then we'll ID the main culprit, look for clues, nail the diagnosis, and finally, talk about the treatment plan.
First things first, we have to get a solid grip on the fundamental problem here. I mean, what is actually going on inside that chest when we talk about restrictive cardiomyopathy?
So here's the absolute key. The heart isn't weak, it's stiff. The ventricles can squeeze just fine. That's what preserved contractility means. But they can't relax and stretch out properly to fill up with blood. That filling problem, that's the whole shebang.
Okay, let's keep building on that, because when a heart gets this stiff, there's usually one main bad guy behind it all.
This is a massive PANCE pearl, you guys. When you see restrictive cardiomyopathy on a test, your brain needs to light up and scream amyloidosis. It is far and away the most common cause, and honestly, we're diagnosing it a lot more now thanks to better tests and just knowing what to look for.
Now, what's really interesting is that there are two main flavors of amyloidosis you have to know. There's AL amyloidosis, which is caused by these immunoglobulin light chains that are straight up toxic to the heart cells. Then you have ATTR amyloidosis, which comes from a protein called transthyretin that misfolds and just gums up the works. And just look at that difference in prevalence. The wild type, ATTR, which happens as people get older, is way, way more common. So you're probably going to see this.
Now, amyloidosis is our #1 suspect, for sure. But you always got to keep a broad differential, right? Other things that can infiltrate the heart, like sarcoidosis or storage diseases like hemochromatosis, can also give you this stiff heart picture.
So now that we kind of know the why, what about the what? What clues are we going to find when we actually see our patient? These signs and symptoms are what will point us in the right direction. This is a really key clinical pearl. Because those stiff ventricles can't accept blood from the body, it all backs up. So you're going to see signs of right-sided heart failure more than anything else. We're talking jugular venous distension, big-time peripheral edema, and an enlarged liver, hepatomegaly. It's much more that than, say, crackles in the lungs.
And this right here, this is your classic board question. They love to make you tell the difference between restrictive cardiomyopathy and constrictive pericarditis. The biggest giveaways? In restrictive disease, the pulmonary artery pressure is always jacked up, and the BNP is going to be way higher. You've got to know those two differentiators.
And if you happen to see these specific findings on your exam, well, the alarm bells for amyloidosis should be going off like crazy. Raccoon eyes from easy bruising around the eyes, a really big, thick tongue, even things like numbness and tingling from peripheral neuropathy. These are huge red flags that amyloid is depositing all over the body.
All right, we've gathered our clues. Now it's time to bring in the heavy hitters and confirm our diagnosis. This is how we go from I think it might be this to I know it's this.
You know, the workup is actually pretty logical. You start with the simple stuff, blood and urine tests to look for those light chains you see in AL amyloid. If that's negative, then you move to this really cool nuclear scan, the technetium pyrophosphate scan. It's awesome because it can diagnose the ATTR type without ever having to stick a needle in the heart. A biopsy is really more of a last resort these days if things are still murky.
Okay, everybody listen up. This is the classic high-yield mismatch you absolutely have to burn into your brain. The echo shows a big, thick, beefy heart muscle, but the ECG shows low voltage. Now, why would that be? It's because that amyloid protein that's clogging up the heart doesn't conduct electricity. It's a massive clue for an infiltrative disease.
And here's another great little imaging buzzword for you. On the echocardiogram, the amyloid deposits literally make the heart muscle look kind of bright and glittery. So if you ever see a report that describes a speckled myocardium, your brain should just immediately leap to amyloidosis.
Cardiac MRI can give us another really key piece of the puzzle. It shows this classic pattern where the contrast dye, the gadolinium, gets taken up all over the infiltrated heart muscle. This late gadolinium enhancement is super suggestive of amyloidosis.
So we've got our diagnosis locked in. Now what? What's the plan? This is where things have gotten really exciting in the last few years, making that accurate diagnosis more critical than ever.
And this is exactly why that initial workup is so important, because the treatment is completely different depending on the type. For AL amyloid, you're treating the underlying blood cell problem with chemotherapy. But for ATTR, the whole goal is to stop that transthyretin protein from misfolding and clumping up. And for that, we use a stabilizer drug.
For that ATTR type,
This drug, tafamidis, has been a complete game changer. It's the only therapy approved by the FDA, and studies have shown it reduces mortality and keeps people out of the hospital. It's a huge deal in managing this disease.
So on top of those really specific amyloid treatments, we still have to manage the heart failure symptoms. And really, the goal is to give that stiff heart more time to fill. So we use things like beta blockers to slow the heart rate down. Diuretics can help with fluid, but you have to be really, really careful not to make the patient too dry and actually make their filling problems worse.
And here is a critical warning. This is a huge safety point and definitely fair game for your exams. Do not use digoxin in these patients. That amyloid protein can actually bind to digoxin, which makes it way more toxic and dramatically increases the risk of life-threatening arrhythmias. Just avoid it completely.
Okay, let's bring this all home with one final thought to really guide you in the clinic. How do you make sure you don't miss this diagnosis?
Remember this clinical picture. You've got a patient who comes in with heart failure symptoms. Their echo shows a thick left ventricle, but their squeeze, their ejection fraction, is actually not that bad. That combination should set off alarms in your head and make you think about an infiltrative process like cardiac amyloidosis. And now that we have really effective treatments, making that diagnosis early has never, ever been more important.